Cross-Connect team, could we have Dr. David Matthews' CV slide? So it's an honor to welcome Professor David Matthews, who requires no introduction in the field of diabetes care worldwide. He has been the recent president of the European Association for the Study of Diabetes. He is the emeritus founding chairman of the Oxford Center of Diabetes, Endocrinology and Metabolism, the emeritus professor of diabetic medicine at the University of Oxford, the past NIHR senior investigator and founding director of the Oxford Health Alliance. He's also an emeritus fellow at the Harris Manchester College, Oxford, having been the vice president and dean also. His research interests include personalized medicine, the etiology of non-insulin dependent diabetes, therapeutic agents in type 2 diabetes, mathematical modeling of insulin resistance. Indeed, the well-known HOMA model, which all Indian researchers and researchers indeed across the world continue to rely upon for their research work. His work on the incretin axis, on the glucagon-like peptide 1, his interest in pulsatile insulin secretion, and the emerging global obesity epidemic. He was on the steering committee of the landmark UK-PDS study in type 2 diabetes, which showed us the importance of glucose control in preventing the onset and progression of microvascular diabetic complications, and also in the follow-up of the UK-PDS study, the legacy effect and its eventual effect on macrovascular disease. He also chaired the EASD-ADA group, which produced the international guidelines for treating type 2 diabetes in 2012 and 2015. He's a co-chair of several large multinational, multi-center randomized controlled trials in diabetes, such as the CANVAS study, the CANVAS-R study, the VERIFY study. Dr. David Matthews, it's indeed a pleasure to have you here with us today on this virtual panel. And we are so honored by your presence, and we look forward to listening from you. Over to Dr. David Matthews, and request you to share your screen. Dr. David Matthews?
I think Dr. David has lost his connection. So meanwhile, he will be reconnecting within.
Yes,
I think
he's already here.
Yeah.
Welcome again, Dr. David Matthews. Request you to share your screen. It's an honor to welcome you.
Well, thank you very much for that introduction. Sorry that the technology threw me out briefly. But I'm delighted to be talking to you today. So I'm going to be talking today about early combination therapy in type 2 diabetes, concepts and new evidence. These are my disclosures. I won't go through those in detail. Now, the recent ADA ESD guidelines are fairly complicated, and they have a vast amount of information in them. But the interesting thing is that the first-line therapy is still the same as it was 10 years, 15 years ago, even 20 years ago. That first-line therapy is metformin and comprehensive lifestyle, including weight management and physical activity. And we haven't changed that opinion over many years. But if we look at now at what we understand about type 2 diabetes, it's best summarized here by Ralph de Fronzo's idea of the ominous octet. In other words, we were thinking that there was a problem with the pancreas. We knew that there was a bit of a problem with the glucose production in the liver and some insulin resistance in the muscles. But now we understand a great deal more about type 2 diabetes. There's an incretin effect that we need to take account of. There's lipolysis. We know that the kidneys change their renal absorption. We know that there's a lot going on with neurotransmitters. And apart from insulin secretion, we've got increased glucagon secretion as well. And all of these contribute to the hyperglycemia of the ominous octet. Now, metformin, which is the original way that we've been treating diabetes, as I say, for decades now, has some effect on increased glucose production from the liver, and also has some effect on the muscle glucose uptake. So this is really an agent that affects technically insulin resistance. But you can see that metformin is addressing only 2 of the panoply of the 8 reasons that we think you're getting hyperglycemia. So if we then think about pharmacological approaches to managing type 2 diabetes, we've got drugs in combination to act on the multiple pathophysiological defects. So should we be using those? Should we use treatment targeting the pathogenic abnormalities and not simply reducing hemoglobin A1C? And indeed, should early treatment be used in order to prevent the decline of beta cell function? Because we now know that glucose itself is toxic to the beta cell, so that we've got glucotoxicity as an additional problem. So if we think about early combination therapy as a strategic approach and think about synergistically tackling multiple pathophysiological mechanisms, potentially resulting in more durable treatment effect without increasing the risk of adverse events, that would be worthwhile pursuing. So if we come back to the ominous octet here and say, well, at the moment we've got metformin acting on the liver and acting on the muscle. But if we were to put in a DPP4, then we would have something acting on insulin secretion, something changing our incretin effect, it would change lipolysis, and it would potentially change the increased glucagon secretion. And then we would be addressing almost all of the problems that we've got contributing to hyperglycemia. So this would be a simple combination therapy. So then the question arises to combine or not to combine at the start of glucose-lowering therapy. And that divides into a couple of questions. Do those with type 2 diabetes benefit from having combined therapy at the beginning of their pharmacological treatment? That's straightforward. But the interesting thing is then, do those with type 2 diabetes benefit more from having combined therapy at the beginning of their pharmacological treatment compared to a sequential additive strategy? Because at the moment, the strategy is you give people metformin and then they fail, and then you give them another agent on top of the metformin. And then the obvious question about both of those things is, does it matter? Well, we know that glycemic targets are important for diabetes management. And here you see on the left the updated mean hemoglobin A1C concentration in the UK PDS, and looking at adjusted incidence per 1,000 person years for here microvascular endpoints in blue, and here the open squares here and the red line for myocardial infarction. And you can see there isn't really a threshold, so that people who decide to choose hemoglobin A1C targets up here neglect to see that actually keeping glycemia near normal is something that we've got some really straightforward evidence for. And that comes out of the UK PDS. But if we also look at retinopathy, and here's the work by Stephen Colliguri published in Diabetes Care, looking at a huge number of patients with retinopathy and looking at the hemoglobin A1C by 0.5 intervals. And it's these data that start to say, well, we're going to choose something around here as the threshold for microvascular disease, so that, for instance, below 6% of hemoglobin A1C, basically you get no retinopathy. And then you can choose somewhere between 6.5 and 7 as what it is that you might think as a reasonable target for diabetes treatment. Now, if we look at ADOPT, which is quite an old study now, but has the advantage that it looked at monotherapy, you can see that with time, you get failure whatever you're using. So although glyburide, that is glibenclamide, worked very well to start with, it failed rather faster. You can see here with rosiglitazone that you get less of an effect, but it failed slower. And then the green line here is the metformin in between. But you can see here that all the time you're getting progressive failure. And this isn't the failure of the agents, it's failure of beta cells. You could argue as to whether sulfonylureas were causing more failure of beta cells or not. And that debate has been one that has been going on for some decades. Now, what about the evidence that we've got so far? Well, the UK PDS and ADOPT, which I've shown you, are data relating to people who were newly diagnosed. In other words, the UK PDS took people absolutely at the beginning of their course of diabetes, and so did ADOPT. But if we look at all of the other outcome trials that we've got, VADT, LEADER, DECLARE, ACCORD, CANVAS, EMPA-REG, Carmelina, SAVOR, TIMI, ADVANCE, TCOS, and so on, all of these have recruited patients at about 10 years or even above in order to see whether they've got cardiovascular outcomes. Because one of the problems of choosing people who are newly diagnosed is that you might have to wait a long time for cardiovascular disease to occur. Indeed, you don't want to run a trial where the investigators are more likely to die than the patients. You do need a signal. And in order to get signals, people have chosen to recruit from this area. But remember that what we then can't do is to say that if we know what is going on at 10 years plus, it necessarily is the same at years 0 plus. Now, the VERIFY trial was different in that it studied over 5 years patients who were newly diagnosed, and this was published last year. And the VERIFY study was taking newly diagnosed type 2 diabetes with primary defined failure threshold over a 5-year treatment period during which patients' treatment was consecutively intensified if clinically indicated. So here we took a broad range of ages, a broad range of BMI. Hemoglobin A1C is quite low here because the people were newly diagnosed. EGFRs, essentially normal. Type 2 diabetes for less than 24 months, actually almost all less than 1 year. Drug naive, maximum 4 weeks on metformin. And it was a worldwide trial, and you can see here that there was a big Indian population, and we recruited 2,001 people overall, but with a worldwide spread of recruitment. So we're looking at time to failure. So failure is simply defined in the study as a hemoglobin A1C greater or equal to 7% or 53 millimoles per liter, millimoles per mole of hemoglobin A1C. And they had to be confirmed. So it wasn't just a one-off. So you recruit here, and after 3 months, it's possible that you could have a hemoglobin A1C greater than 7%. You'd have to wait another 3 months to confirm that. And so the earliest failure in this trial is possible at 6 months. So you can fail at that point, and then you can move on to the next part of the study. Or you might fail later, or indeed, you might stay in the study and not fail at all. And we'll see what failure means in terms of therapies. So the randomization was that you would either go on to metformin and placebo or metformin and vildagliptin. So neither the investigators nor the patients knew which. And then the time to failure was that at the point at which 7% was exceeded, all the people on metformin and placebo who'd failed jumped onto a combination therapy. All the people on metformin and vildagliptin who failed stayed on the combination therapy. In other words, they were all then on combination therapy. So you can see now that you've got, at this point, anybody who fails further, you've got two groups, one who has always been on metformin and vildagliptin, and one group who started off on metformin, failed, and then moved to a combination. This is the usual paradigm for treating type 2 diabetes, the sequential paradigm. So then the time to second failure, often onto insulin, is such that after the first failure, there are various things. You can stay high, in which case you go on to have a confirmation of 3 months apart that you're still above 7, and therefore at 1 year, you've got 2 further verifications of failure. And then at that point, you go on to insulin or indeed negotiate what else you might do. Alternatively, it might be that the treatment is successful and there's no failure, in which case you carry on up to 5 years. So depending on what then happens. So the baseline characteristics were very straightforward here, and I'm not going to go through these in any detail other than to say about half the people were women. They were a median age of 54. You can see here that 3 months was the median duration, so very early on in type 2 diabetes. Hemoglobin A1Cs, as we've said, 6.7 and 15% or thereabouts of current smokers. So then we look at the time to failure. The rate of failure is calculated in each strategy group by an assessment of those failing as a proportion of those in that group. In other words, how many people on metformin and placebo get above the threshold of 7, and how many people on the combination of metformin and vildagliptin get above the threshold. So there's time to failure, the primary outcome, and it addresses the question, do those with type 2 diabetes benefit from having combined therapy at the beginning of pharmacological treatment? And here is the outcome of that. So the initial monotherapy here we see compared with early combination therapy. And you can see here that there's an extraordinary hazard ratio of 0.51. In other words, you're doing twice as well to be on early combination therapy as being on initial monotherapy on metformin. You can simply say, well, that's because you're on 2 agents here and you're only on 1 agent there, and that is absolutely right. But also you can say, well, in a world where we get clinical inertia, nevertheless, these people were doing very much better for a considerable period of time in the early period. And you can see here the difference between 3 years as the median for people who are on metformin and placebo, compared with beyond 5 years as a median failure rate for people who were on the combination therapy. But now the interesting question is, well, let's have a look at whether it mattered, whether you stayed on combination or whether metformin plus placebo, and then you move to a combination. Because many people are saying, well, why would you bother to put people on early? We can do that sequentially. So now everybody now going on to insulin, you can see here, or failing for the second time, is on the combination therapy. The difference between these two groups is only that one group has been on the metformin and vildagliptin from the outset of the trial. So the rate of failure in each is calculated in each strategy group by, again, an assessment of those failing as a proportion of all those in that group. Obviously, that's the people who fail are on insulin and everybody else is not on insulin. And this addresses the question of, do those with type 2 diabetes benefit more from the combined therapy beginning at the pharmacological outset compared to sequential additive strategy? And here you see the time to second failure. Remember, all of these people are on combination therapy, but this group were on metformin to start with, and this group, for the early combination therapy, were on the combination from the start. And there's a significant difference here with a very significant hazard ratio and confidence intervals well clear of unity with a p-value of 0.01. So what this is showing is that at the time that you're needing to give a third agent or put people onto insulin, you have done extremely much better with a hazard ratio of 0.74 from early combination than you were on initial monotherapy. So if we look at the rate of loss of glycemic control, you can see that in the ADOPT study. These are purely followed. You don't do anything else in terms of adding therapy. If we look at what happened in Verify, of course, here's the combination therapy, and here's the initial monotherapy. But of course, these are biased downwards by therapeutic addition on the survivor population. So these are not pure, but you do see within this the gradual onset of beta cell failure in the early years, exactly as you saw in ADOPT. So look at the success rate of treatment between the approaches. And here, what we're looking at is a hemoglobin A1C less than 7. And if we look at the people who are on early combination compared with initial monotherapy over the whole trial, you can see here that 100% of people coming down here on early combination therapy, and much fewer people on the initial monotherapy achieving that threshold of an A1C of less than 7. But actually, you can, of course, look at, well, did they achieve hemoglobin A1Cs less than 6.5? And again, you see a clear signal here with all of these blue bars being higher, meaning you were doing better on early combination than you were on initial monotherapy. And even if you wanted to take a hemoglobin A1C of less than 6%, again, very strong signal here for early combination therapy over the whole of the 5-year period. Now, Verify wasn't a cardiovascular outcome trial. You'd be rather crazy to do a cardiovascular outcome trial these days from the outset. UK-PDS did, but then we didn't know at the stage that we were running the UK-PDS whether 15 millimoles per litre of fasting glucose was dangerous. And that was one of the questions that UK-PDS had to answer. And the answer is it was. So these days, you can't do an ethical trial and allow some people to have a very high glucose. So by and large, you don't get many events early on, which is why when I showed you the trials, people choose people who are 10 years into diabetes and with risks. But we did adjudicate all the cardiovascular events, and the adjudication was performed by an independent committee masked to the treatment strategies. And there was an independent data monitoring committee which monitored the safety. And the total adjudicated events here were 30 in the early combination therapy and 44 in the initial monotherapy. And this is what the Kaplan-Meier looked like. Now, this isn't significant. Look at this p-value. This is 0.19. And indeed, look at how low the numbers are. But nevertheless, there's some sort of signal going on here, which shows initial monotherapy compared with early combination therapy. And whatever else you believe about this, it's not doing any harm in terms of cardiovascular output. But we put this huge caveat here, meaning beware, small numbers and wide confidence limits. So you don't want people to run away and say that this trial demonstrated that there was a macrovascular event benefit from this trial. But I show you the data for full disclosure. So we then come to the whole idea of, do those with type 2 diabetes benefit from having combined therapy? Does it matter? And the secondary outcome of, do those with type 2 benefit more? And we can think very briefly about this. So do those benefit from having combined therapy at the beginning? And the answer is yes, we're absolutely sure that they do. And here, over all of this early period before you get failure, people are doing better in terms of glycemia. So the first failure into combined therapy is a test of one agent against two. Does it tell us anything useful? And it does, because we can ensure earlier and better glycemic control that may be more durable, with low risk of hyperglycemia and no body weight gain, and therefore improving patients' adherence to treatment, and possibly reducing clinical inertia and offering more opportunities to address individual patients' needs. Then there's a question of secondary outcome. Do those with type 2 diabetes benefit more from having combined therapy at the beginning of their pharmacological treatment? And here, as a reminder, is that particular Kaplan-Meier. By the second failure, all patients who failed were on combination therapy. And so when we look at the management of hyperglycemia in type 2 diabetes, the consensus report from 2018, it says that while there is some support for initial combination therapy due to the greater initial reduction of A1C than can be provided by metformin alone, there's little evidence that this approach is superior. But that was 2018. And in 2020, we would cross that word out and say, there is now evidence that this approach is superior to sequential addition of medications for maintaining glycemic control or slowing the progression of diabetes. Does it matter? Well, early combination treatment halved the risk of time to initial treatment failure. The median time to failure was 3 years in the initial monotherapy strategy compared to over 5 years in the early combination strategy. And when all patients were receiving combination therapy, the risk for time to second treatment failure was reduced by 26%. And both approaches were safe and well tolerated. So the conclusion is that the strategy of an early combination treatment approach with vildagliptin plus metformin in patients with newly diagnosed type 2 diabetes significantly and consistently improves long-term glycemic durability compared with metformin monotherapy. Now, you may ask, well, is this a vildagliptin specific finding? And the answer to that is, I'm almost sure it's not. I think that early combination therapy, we need to do a lot more in terms of investigation as to whether other agents would do just as well or better. But certainly vildagliptin is the only agent that we've got that has shown this in the trial. And these are the publications. Now, we will know a bit more next year because the GRADE trial is going to report, and that's the glycemic reduction approaches in diabetes, a comparative effectiveness study. And this is a pragmatic, unmasked clinical trial. It's recruiting people who've had diabetes for less than 5 years. So again, not really from onset. And with a baseline hemoglobin A1C of 6.8 to 8.5. So again, people who've got significant problems with glycemic control compared with what we produced in Verify. And that's going to report in exactly a year's time. So let's go back to the ominous quartet just to finish off then, because here we've got a combination therapy which is addressing many aspects of hyperglycemia. And if we therefore reduce the hyperglycemia by using combination therapy, then that itself is an advantage in terms of microvascular disease. But then there's also the reality that we've got an increased longevity of effect. In other words, you fail less quickly. And then there's a signal for reduced complications. We've then got a reduced need for insulin and a reduced need for follow-up. And then there is absolutely the question of costs. And that's a balanced question because actually, if you're going to get less complications and you need less follow-up time, in other words, you could put people on combination therapy and not necessarily need to monitor their decline so much, there might be some cost savings. There would certainly be some cost savings with the fact that less people go on to insulin. On the other hand, there is a cost of putting people onto these agents early on. But as time goes on and these agents come off patent, I'm sure that the evidence for the cost effectiveness of this will accumulate. So if you have been, thank you very much for listening.
Thank you, Dr. David. The Cross Connect team, I hope I am audible.
Yes, sir.
So thank you, Dr. David, for a very wonderful lecture covering the early combination therapy. There are lots of questions. So the first question to Dr. Matthews is that very difficult question. Is it possible to extrapolate the Verify results for metformin plus SGLT2 inhibitors? What is your personal view on that?
Well, it's an interesting question. You'll know that the European Society for Cardiology thinks that the evidence for putting people onto SGLT2 inhibitors is very good and that people with cardiovascular disease should go on early. All one can say is that I think that's probably a pretty good idea, but it's only an idea, and we should be careful of thinking that we've got an evidential base for this. So I think in time, we need the SGLT2 inhibitor pharma companies, and indeed the GLP-1 pharma companies and others, to say, well, if they think that that's a really smart idea, then do the trial, do a verify-like trial and say, look, you get real benefits from this, starting people off on these agents from the beginning. But it is an evidence-free zone. And my own view about it is to say, sure, do I, in my gut, do I think that this is a good idea? And I think in my gut, it probably is, but it's jolly expensive and you might not need to do it for 10 years. And what we know is that it's pretty good when you've got established cardiovascular disease. But I think it's an expensive thing to do, to extrapolate that to newly onset diabetes and just say, well, why don't you take a couple of agents, really expensive agents, when your hemoglobin A1C is only slightly raised? And, your healthcare system and our healthcare system and United States healthcare system just can't afford that stuff. So let's find out what works, and really let's find out whether it's worth it. We've got to do cost-effective analysis on these things to say, look, if you put people on combination therapy, they get less complications. Complications are hugely expensive, And SGLT2 inhibitors will stop some degree of renal failure. So, there's a cost-effective argument there. But I'm sorry, we need to do the work and find the evidence.
Thank you for that answer, that we need to wait for evidence on that. I've been just told by the organizers that we have 5,500 plus participants, and that's really good to know that we have so many participants who are listening in right now, and that's thanks to people like Dr. David Matthews, Dr. Samir, and Dr. Ajit out here. The next question is on pioglitazone, and you did allude to the ADOPT study in one of the slides. So the question is, can pioglitazone be used in elderly males? Risk of fractures. Isn't it a drug with a lot of side effects? How has been the UK experience of using pioglitazone, and do you continue to use it as you did earlier?
Yes. Well, Ralph DeFronzo is a great protagonist for pioglitazone, and I've used quite a lot of it in my life. It's pretty safe. It's affecting insulin resistance, and you don't get hyperglycemia with it. So there are some advantages to it. On the other hand, it does have side effects in terms of weight gain and swelling of the ankles and so on. And it was alleged that you were going to get better outcomes from non-alcoholic steatohepatosis. And there's a bit of evidence for that. But actually, the newer agents like the GLP-1 agonists look as though they're going to be better for that in the long term. So yes, pioglitazone is not dead in the water. It can be a useful agent. It's relatively cheap. Just keep an eye on those swelling of the ankles, and just use with a little bit of caution. But certainly for people with significant insulin resistance, it's quite good. There's a tendency to put on weight rather than with the GLP-1 agonists where you lose weight.
Thank you. Would just like to take a moment to welcome Dr. Padma Srivastav, Professor and Head of Neurology from the All India Institute of Medical Sciences.
Good evening.
Nice of you to join in, and good evening.
Thank you. Great to be
nice
in.
to see you.
Good evening. Yeah.
Yes, thank you, ma'am. And Dr. Suryakant, Professor Suryakant, also welcome to you, sir. And next question again to Dr. David Matthews here. Do you use, in the UK, do you use medications for pre-diabetes? And have you prescribed medications, any combinations for use in pre-diabetes, and your views on that?
Well, I showed you the Steve Colagiuri data about complications of microvascular disease. And my own view is that pre-diabetes is entirely pre-pathology. I don't see the point of treating people pre-diabetes. I think if we think you're at risk, then let's have an argument about it and reduce the threshold for what we think is diabetes. But I think the whole concept of pre-diabetes is a risky one. It's certainly risky in terms of costs to healthcare provision if you start thinking that that you want to use pharmacological therapeutics. On the other hand, the concept of pre-diabetes for an individual is to say, hang on, you're getting quite close to having diabetes. You better do some serious exercise and weight loss and so on. And then I think that's a really useful concept. But it isn't a useful concept in terms of therapeutics. I think, either you've got an illness, in which case we might give you some pharmacotherapy, or you haven't, in which case we won't. But the concept of saying you're near the edge, guys, is a really good one. So that's where I think we need the concept of pre-diabetes, quite useful for clinicians and quite good for looking at and encouraging people to lose weight.
Well, we are. I think it has been a wonderful discussion, and there's one more question before we go to the next panel discussion on the COVID pandemic. One more question to Dr. David Matthews. In diabetes, the question by the delegate asking the question is that in diabetes, you have so many cardiovascular outcome trials, and some of these trials work, and some of these trials haven't worked. And now that Verify has shown some cardiovascular data, and of course, all the gliptins, sitagliptin, saxagliptin, all these gliptins have had cardiovascular outcome trials, and some of the SGLT2s have had cardiovascular outcome trials which worked, and some of them, like for example, the ertugliflozin trial didn't work too well. So, what is to be kept in mind when interpreting a cardiovascular trial, and why do some of these trials work in diabetes and some of them don't work in diabetes, and your views on that?
Yep. Well, a very interesting question. One of the problems with regulators, and the trials are done to impress regulators, is that the regulators have said, look, if we're going to look at the safety of an agent, it's no good having a difference between the glycemia of one group compared with another. We need the glucoses to be approximately the same, you see? So otherwise, you might have a poisonous drug, but you might be saving people's lives by having a lower glucose. So they say we want equipoise. Now, if you look at the trials, what happens is that you put people on agents and the placebo goes horizontal, but then the therapeutic agent does this, but they come together again because they're blinded trials, and you say to all the investigators, try and maintain the glycemia the same. Now, that means that if you have a drug which does things other than glycemia, like the SGLT2 inhibitors, which changes your weight and your sodium and the blood pressure and all the rest of it, then you can get a fantastically good signal because you're not constrained by the FDA to keep the glucose the same. But just imagine for a moment that if you produced a new antihypertensive to treat blood pressure, and the FDA said, oh, yes, but we want the safety of this, and you're not allowed to have a difference between the blood pressure. So you can trial on your ACE inhibitor, but you've got to keep the blood pressure the same. You think, well, what world would we be in if we did that? These agents for lowering blood sugar were designed to lower blood sugar. And yet in the cardiovascular outcome trials, that's the one thing you're not allowed to do, is to maintain that difference. If you had a new antibiotic, can you imagine what would happen if the FDA said, well, we want to find out whether this is toxic. So we're going to have the same bacterial load in both people while you test out your agent. And then you'd find a trial where it didn't seem to work. But it's no good testing agents when you're not allowed to do the one thing that they were designed to do. So DPP-4 inhibitors were designed to lower the blood glucose, right? They do that rather well, but they don't have a lot of additional effects, but they really do lower your blood glucose. And so all of those trials like SAVOR, TIMI, and EXAMINE and so on, which people say, oh, there was no difference. The answer is, no, there wasn't a difference because they weren't allowed to use the one thing that would make a difference, which is the glucose difference. And then they say, but look at the, EMPA-REG. And the answer is, yes, but all of those are peripheral effects that we didn't think were going to happen and which the FDA hadn't controlled for. So it's a very strange world that we live in. But I think that people need to be very careful about saying that those trials were negative. They are safety trials, and they were, because they were negative, they're positive trials to say, yes, it's safe. But they don't tell you how good they are in clinical practice because you weren't allowed to use them in clinical practice.
Thank you for that answer. And you heard it from the master himself, who's led so many diabetes-related cardiovascular trials and has also been on the UKPD study. Thank you, Professor David Matthews.